You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, and today we are joined by ONS member Lauren Suarez, nurse manager of radiation oncology at Miami Cancer Institute in Miami, Florida, member of the ONS Miami-Dade Chapter, and member of the advisory panel that developed ONS Guidelines on Radiodermatitis. Today we're discussing this treatment side effect and ONS's clinical guideline recommendations for managing radiodermatitis in patients with cancer, which published in November 2020. Thanks for joining me today, Lauren.
Thank you for having me.
To start us off, why should clinicians be concerned about radiodermatitis?
Well, radiodermatitis is one of the most frequently documented adverse effects during radiation therapy. If it's not properly addressed, it can be dose limiting, leading to delays or even discontinuation of treatment, which affects the patient's prognosis. It can also be a huge burden to patients who deal with pain and discomfort and limitations with what they can do when they have it. So we really have to be cautious with it.
So what patients are at risk for developing this side effect?
Any patients receiving radiation therapy are at risk for developing radiodermatitis. It's been widely reported that up to 95% of patients develop some form. It can be from stage 1, which is just a slight erythema, to stage 4, which is a weeping open wound. We can't always prevent it, but we can minimize it as best as possible. There's a lot of misinformation regarding who is at risk for it. So some people think that because of skin pigmentation or their ability to tan, they might not get a skin reaction, but those are not valid predictors. It can be anybody. That's why it's important for clinicians to regularly assess their patient's skin and encourage them to follow guidelines to help minimize these reactions.
So I'm thinking that in the guidelines, you all have looked at the evidence of what the best way to manage this side effect is. And it's always been a challenge for clinicians and patients with a lot of topical interventions available on the market. So what did you guys find in your review?
The panel looked at a wide variety of studies on radiodermatitis, and it was found that the research was just as widely varied. Many different interventions were looked at, and a lot of those interventions were not always practical or used clinically in practice. Considering the various factors, including the cost, compliance, and accessibility, we decided that in many cases, the standard of care, which is gentle washing of the area with mild soap, using mild lotions, protecting it from the sun, was most effective and appropriate in many situations.
Great. So despite many of the different specialty creams and topical lotions on the market for skincare during radiation, the ONS guideline panel recommended standard skincare rather than specialty creams. Can you talk a little bit about why that decision was made? Like, for example, specialty creams don't have good evidence that they're effective and they're expensive.
Like you said, in many of the studies, the specialty creams were shown to be either equally or less effective than the standard of care. And with the increase in cost and questionable effectiveness, we decided that specialty creams shouldn't be recommended. They pose an unnecessary burden to the patients that we didn't want to include in their treatment, which is already difficult enough.
I think that is really hard for patients because, not only are they experiencing that side effect and being uncomfortable, so frequently, but then they probably have family members that are very well-intentioned who are, coming along saying, well, I've used this for something and I've used this for a burn, and how hard that might be for, patients. And then if they, do come in and are seen, and are they being forthright in telling their practitioners or the nurses what it is that they are using. But along those lines, with family coming in and giving them ideas and things like that, what are some misconceptions about radiodermatitis and ways to treat it?
One of the big things I see in my practice, I work in a very heavily Hispanic market, and the family often wants to put Desitin all over the patient's skin. it's a very cultural thing. I'm also Hispanic. We use Desitin for everything. But the Desitin has some aluminum in it, which can cause a bolus-like effect at the skin and actually increase the risk of skin reactions. So we really are highly recommending against that and hoping that patients will take the guidelines into consideration. We also have many physicians that prescribe aloe vera. The studies with aloe vera were not easily reproduced because they use specialty compounds of the cream that aren't commercially available. And the straight aloe vera 100% was not studied enough to be able to recommend it. So we just went with the standard skincare.
Great. So can you explain to us why using deodorant or antiperspirants with radiodermatitis is controversial?
So this was a topic I was very verbal about during the guidelines panel. There was no evidence for or against the use of deodorants and antiperspirants. I live in Miami, where the heat and humidity results in a lot of perspiration. Patients are already burdened during treatment, feeling isolated and different from others, having to come in for treatments daily. And putting on top of that to be stinky, I really was just passionate that if the patients want to use it and if it's not going to harm them or affect their outcomes, they should be allowed to use it and shouldn't be dissuaded from it. It's been traditionally a clinician-based recommendation. The physicians often say, don't use deodorant. But if it's going to make the patient feel better to use it, make them feel more normalcy in their life, I'm all for it.
I think that's so important because, like you said, they're already feeling different just because of their diagnosis and because of the treatment they're getting. And then if they're having this side effect or symptom from their treatment that could potentially be, something visual that is seen, and then to have that on top of it, I can see where that would be something that is really important to weigh out what is the risk and benefit of that, and looking at, will it make the patient feel better about just everything that they're going through. So all of the information that you guys gleaned from your review and things like that, what will this knowledge mean to patients?
Patients are really scared at the beginning of treatments. There's a lot of anxiety coming into a radiation oncology department, I think, for anybody who doesn't work in the field. And it can be overwhelming, but knowing exactly what you should do and that it's the standard of care and the recommendation, I think will give them a lot of peace of mind. And knowing that it's as simple as washing yourself with mild soap, using lotions, things that are very simple and practical, I think that'll make that anxiety decrease quite a bit. Knowledge is always power to patients. And if everybody's recommended the same thing, it gives them a sense of they're doing the right thing for their treatment. And traditionally, radiodermatitis has been treated very differently based on the physician's preferences. So I think giving them this as a stepping stone will really give them a strong platform to be able to base their decisions on as far as their own care.
I think that's great too. And I agree with you. I think, the more that we can information that we can give to patients that is evidence-based and that we can give them to empower them, to do their own care and to take care of their side effects and symptom management the best that they can with the help that we can give. I think that will just work out for a better outcome in how they're dealing with everything that they're having to deal with at the time. The ONS guidelines describe standard skincare during radiation therapy. Can you talk a little bit about what good skincare entails?
Good skincare is just during radiation is washing with a mild soap, one of your preference that's not going to be harsh or overly drying, making sure to pat the skin after instead of scrubbing it so that you're not damaging the skin any further, making sure you're drying it well so you're not breeding any additional bacteria or yeast in it. And then using that light cream, something very mild, hopefully with no scents or colors. That way we can minimize that radiodermatitis. Also protecting the skin from sun exposure. Like I said, I live in Miami where the sun is constantly beating down. So, beach is kind of life here. So it might be a little hard for the patients, but keeping them out of the sun and using good sun protectant also helps quite a bit.
I'm sure that is hard where you're located. And this is a little bit different of a direction with that, but when you're talking about mild soaps and things like that, it just also came to mind. And I don't know if this actually came up in any of your discussions or not, but would you also recommend to patients and family members even their detergent that they use for their clothing be some of those mild detergents that are scent free and things like that, just due to the fact that if they are having to, if their the clothes that they're having is going to be close to those areas where the radiodermatitis might be, would that be an issue?
I think that's very patient specific, and everybody knows their skin better than anybody else. So if detergents are something that can irritate your skin, I would definitely go with whatever's least irritant. I also think that if it makes the patients feel better, then they should also go for it, because if they're nervous and if this is something that eases some of those anxieties, I think it's an easy step that's not life-changing that they can implement, relatively inexpensively. And I also think it's something that would be great for future research to see if patients who use those mild detergents and different washing routines on their clothes have less skin reactions than those who continue to use more heavily or detergents with more dye in them.
The ONS guideline panel suggested using semi-permeable dressings to minimize the development of radiodermatitis. What would oncology nurses need to know about using those dressings in clinical care? Because, you might be getting patients from the inpatient unit and, they're getting combination therapy and being seen in an outpatient clinic and getting treatment. So what are some of the things that you would want to make sure that those nurses would know about that?
So in the research, we saw several different kinds of semi-permeable dressings used. One of them is a cream base that has really good results. So it's as simple as just putting on a cream over it, and that's it. Other ones are a little more difficult. They are more of a traditional dressing with adhesive, and those can be tricky for patients because they're supposed to stay on the length of the treatment. We found that some of those in studies had very low compliance rates. So this was also a topic that we discussed back and forth quite a bit, because in the studies, patients that did continue to use the semi-permeable dressings, they had great outcomes. But the patients that fell out of this study, the numbers were pretty high. So we wanted to make sure that the patients, if they wanted to use them, knew that we do recommend them. But if it's going to be detrimental to their ability to actually do the treatment, then they should look at other options. We also looked at semi-permeable dressings once the patient did have a skin reaction that was, a little bit moist. And we found that those were very effective in helping wick away that moisture and keeping those wounds, clean and dry, which is important. It also made the patients a little more comfortable in practice.
Are those dressings easy for the nurses to get a hold of, to use? Are they things that are normally available in the hospital settings, or are these more specialty type of dressings that would need to be ordered in?
The dressings for prevention of radiodermatitis are rather specialty items. I don't think most hospitals would have them in stock. My center is one of the bigger radiation oncology centers in the country, and I know that our inpatient units do not generally stock them. But the dressings for the skin, once you do have a skin reaction, are very widely available. They're often used for pressure ulcers and other wounds around the department, things like Mepilex, dressings like that are moisture absorbing and mild. They're pretty widely available in hospital units.
Okay, great. So what's something about radiodermatitis that's not often discussed, but you wish people knew more about?
I think the one thing that's not often discussed is that we don't have a way to 100% prevent it. We're not looking at the prevention of it. We're looking at decreasing the amount of radiodermatitis they get, decreasing the grade, keeping patients at a grade 1 or 2, because they will have skin reactions depending on the treatment site. Some treatment sites have more severe skin reactions. What if the skin is more delicate? Patients who are getting treated to the head and neck and breast, they will see skin reactions in a lot of cases. I think it's minimizing those skin reactions. That's really the goal that we're going towards. And I think that's the goal for most radiation oncologists who are looking at different treatment modalities and different treatment planning that can help minimize it as best as possible.
Can you just briefly describe maybe what the range of radiodermatitis might be that a patient might see, or if that patient is getting combination therapy and ends up in in their outpatient setting and the nurse in the outpatient unit is doing their assessment? I realize that there's probably a wide range, but what are some of the common dermatitis that you would see? What would they be looking for, or what would it look like?
So, radiodermatitis per the NCCN guidelines is graded from 1 to 5. Grade 1 is a light erythema. It is like a mild sunburn, almost, you would say. It's a little uncomfortable, but nothing that would hinder you. Grade 2 is more redness, a little more pain. The skin is still intact and closed. Grade 3 is when we start to see that dry desquamation. The skin is more open, there's small spots of openness. A lot of times in the skin folds or in the crevices of the wrinkles in this or folds in the skin, and that is painful. Grade 4 is that it is bleeding on light touch. It's very angry looking, and you can see that the patients are in a lot of pain. It's going to require pain medications. It will definitely be dose limiting for the patients at that point. Where most radiation oncologists will stop treatment with the grade 4. There may even be hospitalization and antibiotics required. The patients could have some more long-term effects on their skin for the future. Grade 5, as in all NCCN guidelines, is death resulting from the reaction.
So, in addition to the NCCN guidelines on how to grade those, what are some resources for oncology nurses who want to learn more about managing radiodermatitis?
Prior to the guidelines that are going to be published in November, there were the ONS PEEP, the putting evidence into practice. And I always used that to go and see what was recommended, what was questionable, and see how I should be managing these patients. The physicians are also excellent at being able to help you go through that. And any radiation oncology nurses who have a lot of experience, I always look to people who have been doing this for a long time because they have that historical knowledge. And it might not have been studied yet, but they've seen it work. And I think there's a lot of really great studies that can come from traditional practices that just hasn't been looked at as of yet.
Was that something that you found in your review of the evidence, that there are a lot more opportunities for research to be done on specific things?
Oh, it's definitely a huge opportunity for research. Like I said, there was not a lot of research done on pure aloe vera. A lot of it was compounded mixtures that were difficult to reproduce. So, we really don't know if aloe is a good treatment option or not. There's a lot of physicians using cornstarch as a barrier protection for radiodermatitis. And in practice, they see a lot of really great results doing that. But is it truly evidence-based? So I think that would be a great study. And then for the actual open wounds, Silvadene, which is something that is widely used in the radiation oncology community once you get to a grade 3. That has not been studied either, so not effectively at least. They had some studies that started at the initiation of treatment. It's not a normal course to use Silvadene at the beginning before there's any open wounds. So I think that would be a huge research opportunity also, since it is so widely used in practice.
So we talked about the nurses' resources. How about patient-centered resources? What would be available for them?
I always use Oncolink as my patient resource. They have a lot of great things on radiation oncology in Oncolink, including prevention of radiodermatitis. I also look at NCI always. They have great resources available. And a lot of institutions have developed their own radiodermatitis protocols. So I think there's a lot of things out there for patients. But as a nurse, I always think that the patients, one of the best things for patients is to be able to reach out to nurses in the community, be able to talk to them, be able to have them look at it, assess and evaluate, and give them, recommendations and help talk them through how to care for it, because the patients, they need that extra touch that the nurses are able to provide and that encouragement just to get through the treatment.
So true. I think that, they definitely need to have that encouragement and empowerment on what they can do, and that they always have that support coming from their nursing staff. So, do you have any final comments about radiodermatitis or anything else we've discussed today before we finish up?
I would just really like to see more research done in the radiodermatitis realm. And I encourage any nurse who wants to work together on a research project to reach out to any of the panel members. I know a lot of us found that there were different spaces that were lacking based on our experience. A lot of us have been in radiation oncology a long time. So there's ample opportunity where I know everybody in that room was more than happy to be part of developing these guidelines and creating more standardized practices across the world for our patients. So please continue with the research, do things that are reproducible, that are easy for patients to get. We looked at things, and some of the things we were Googling, we were all in the room Googling emu oil, and we found that emu oil is actually the oil from an emu bird. And none of us knew that, and we'd all worked in radiation oncology for a long time. So it might be something you want to study, but if it's not something that's readily practiced or readily available to patients, reconsider and think about things that are being done currently.
That's great. You did mention something that also I just thought of, I'd like to ask you, but when you were doing your review, was there a lot of international evidence or even studies or anything like that you found that were interesting, based or different from what we do here?
I remember one particular study that was from a Middle Eastern country, and because of their holy day, their treatment days were different. So it took us a long time to figure out why the patients were off of the intervention on certain days, until somebody said, well, that is most likely their holy day so they had a different treatment paradigm than we did, where they treated on the weekends and had some days of the week that they weren't doing radiation. And, in the US, it's a pretty standard Monday to Friday kind of treatment paradigm. So that was really an interesting revelation for us. It took us quite a while to work through the rationales and stuff because of it, but it really opened up our minds to the differences around the world.
I'm sure. And I'm sure with everything that's happening in the world right now too, that would have pulled in a whole nother turn of discussions as well during that review for you all.
Yeah.
Well, thank you very much for your time with us today to talk about the new guidelines that we have, and for your expertise in radiodermatitis. And I look forward to seeing what new research might come out and how we can continue to improve patient outcomes, especially in this area of radiodermatitis related to their treatment. So thank you.
No, thank you. It's been a pleasure.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.